Hey guys, it's Dr. Franklin, and in this presentation, we're going to talk about the management of pain and discomfort. Pain can be so prevalent that it overwhelms basic needs, but it doesn't mean that it doesn't serve a useful purpose. After all, pain is critical for our survival because it alerts us to the functioning of our bodies, and this feedback system allows us to make simple and complex adjustments. Pain is the most likely symptom to lead a person to seek out physician assistance. Unfortunately, though, the relationship between pain and serious conditions is weak. For example, cancerous lumps rarely produce pain, but it is of great medical importance. While patients tend to be putting greater focus and emphasis on pain, physicians may see it as a byproduct of a real issue, and thus pain may not be their priority. If patients pick up on the fact that the physician is not focusing on their pain, then this could strain the relationship between physician and patient and make the patient less likely to comply with treatment. Having the symptom of pain addressed by physicians is of critical importance to patients, so much that an inability to reduce pain causes a great deal of anxiety. Did you know that the chief reason why individuals seek euthanasia or assisted suicide is because of pain? It's true, and research has also highlighted how physical pain and social pain in the form of loss or rejection uses the same pain related neural circuitry. The latter finding may help to explain why psychological distress and pain overlap so much. Finally, chronic pain is big business in that it affects nearly 116 million people in the United States, and cost and disability and loss of productivity equate to more than $560 billion. The worldwide pain management prescription drug market totaled 46.4 billion in 2011. Given everything that I've said, hopefully now you see why we need to talk about managing pain and discomfort. The nature of pain can be very elusive because it is primarily a psychological experience. A physician in World War II highlighted this in his observations of injured individuals in the service taking painkiller medication versus those in the general population. He found that 25% of the service members he treated with moderate to severe injuries in World War II took pain medication versus 80% of the general population that took pain medication to assist them with relief. The context of the pain is extremely important. The context of the pain is important as well, given that many athletes have reported instances of playing through pain, and this likely took place because their sympathetic nervous system was so aroused. Sympathetic nervous system arousal has a tendency to numb the sense of pain. Finally, culture plays a role in the elusive nature of pain in that some cultures tend to report pain sooner and react more intensely. Additionally, some individuals have higher levels of sensitivity to pain. For example, women tend to report pain sooner than men. Measuring pain can be extremely difficult because there are no objective measures of pain. For example, if a bone is broken, it is fairly routine to use an x-ray to determine the extent of the break. But pain doesn't have these objective measures. Verbal reports and questionnaires help some physicians to assess pain, and the latter becomes extremely beneficial when patients are not able to describe their experiences. These measures may ask about throbbing or shooting pain, as well as the pain's intensity. Did you know that some physicians rely on drawings of patients to determine how pain is causing emotional distress? Yes, they do. And they also use these drawings to get at one's perceptions of consequences and symptoms connected to their pain. Methodological tools from neuroscience have provided insight on how chronic pain may affect the brain, and that some individuals suffering from chronic pain may have a reduction of gray matter in brain regions essential to processing pain. Sometimes physicians will focus on pain behaviors or behaviors that arise from experiences of chronic pain, for example, distortions in posture, gait, facial, and audible expressions. They'll use these as a means of determining how the pain has affected an individual's life. As we've discussed earlier, the experience of pain is a protective mechanism that brings tissue damage into conscious awareness, and scientists have distinguished between three types of pain. One type of pain is nociception, which is mechanical damage to tissue. One type of pain is dealing with exposure to extreme temperatures, and another type of pain deals with polymodal nociception, a general category referring to pain that triggers chemical reactions from tissue damage. The gate control theory of pain is the basis of scientific understanding of pain. The theory highlights how nociceptors in our peripheral nervous system interact with the spinal cord, which in turn allows information to be transmitted to our brain. In particular, this information is transmitted to the reticular formation in the thalamus, and this information is transmitted so that we can identify the site of an injury and send messages back down to the spinal cord, which can lead to muscle contractions. These muscle contractions can help block pain and change bodily functions such as breathing. Specifically, endogenous opiate peptides block the transmission of pain signals down the spinal cord. These endogenous opiate peptides are produced in many parts of the brain and glands of the body, and they project onto specific receptor sites in various parts of the body. It should be mentioned that reflexes occur without input from the brain, and this highlights how the spinal cord in many ways operates like a primitive brain and saves us from being incapacitated in other life-threatening experiences. To end this presentation, I want to talk about two main kinds of pain. Acute pain is pain that is the result of tissue damage, such as a wound or a broken limb, and it typically disappears once the tissue damage is repaired. Acute pain usually is short in duration, and it is pain that goes on for 6 months or less. Chronic pain, on the other hand, typically begins with an acute episode, but unlike acute pain, it does not decrease with treatment and the passage of time. An important distinction between acute and chronic pain is that chronic pain is usually overlaid with psychological distress, which complicates diagnosis and treatment. Chronic pain may also involve patients catastrophizing their illness, engaging in wishful thinking, withdrawing socially, and all of the aforementioned can complicate treatment and lead to more care seeking than is needed. When pain is endured for a long period of time without any apparent relief, some may believe that the pain will just get worse, and in turn, those thoughts only magnify the distress of pain and create greater pain. Oftentimes, just treating the psychological issue may result in reducing the chronic pain itself. In distinguishing acute versus chronic pain more, it's important to note that acute pain is usually easier to control. Thirdly, chronic pain often involves complex interactions of physiological, psychological, social, and behavioral components, more than is the case with acute pain. For example, individuals with chronic pain receive social rewards from the attention they receive from their social groups, and these secondary gains can help maintain the behaviors by way of reinforcement. Naturally, people may wonder who becomes a chronic pain patient. Well, it's important to note that all chronic pain patients start off as acute pain patients. Chronic pain may result from predisposition to react to a bodily insult with a specific bodily response, in addition to a high sensitivity to noxious stimulation and impairment in pain regulatory systems. Chronic pain could totally alter someone's day-to-day life in a way that highlights how physiological, social, psychological, and behavioral aspects of one's life come together and interact. For example, as a result of dealing with chronic pain, some individuals socially withdraw, leave their jobs, relinquish their hobbies, collect disability payments, have difficulty with sleeping, and their entire lives become centered around management of chronic pain. Chronic pain patients may not communicate well with their families, and unfortunately, their sexual relationships almost always deteriorate. Research has not uncovered a specific personality type that is connected with the experience of chronic pain because the experience of chronic pain is contingent on so many biological and environmental factors. But there are certain personality traits that have been reliably associated with chronic pain. I'll talk about those now. These personality traits tend to be neuroticism, passive coping styles, and introversion. The profiles of individuals that experience pain may involve the presence of the neurotic triad as expressed through the Minnesota Multiphasic Personality Inventory, or the MMPI. So that neurotic triad consists of the depression and hysteria and hypochondriasis scales. It also may involve profiles that include suppression of anger and other psychiatric disorders. There are a variety of different approaches individuals use to manage their pain, as you can see from the slide. One method is the pharmacological approach or medication. Morphine, medication named after the Greek god for sleep, Morpheus, is the most popular painkiller by far, and it is highly effective. Like many kinds of medications, one of the primary issues with its neurotransmission route of reducing pain is its addictive qualities. Additionally, many pharmacological interventions cause a wide range of side effects that are unpleasant, and drug overdose is an ever present concern among clinicians. Surgical control of pain has been practiced, and this essentially involves severing connections of the peripheral nervous system to the spinal cord. Unfortunately, the positive benefits of these interventions seems to be short-lived. Also, the risk and possible side effects and expense seems to be a deterrent for this particular approach. Counter irritation, or inhibiting pain in one part of the body by stimulating or mildly irritating another area, has been employed, but much like the surgical control of pain, the positive benefits seems to be short-lived. Eventually, doctors began to believe that increasing mobility and encouraging exercise was the way to go to help individuals manage their pain. But in times past, it was thought that the less activity, the better. Other techniques to manage pain are more psychological in nature and require active participation and learning on behalf of the patient. Cognitive behavioral therapy techniques that include biofeedback, relaxation, cognitive restructuring, and coping skills involving distraction and focusing on sensory aspects of pain have been found to be more effective for managing slow pains. These slow pains can be anticipated and prepared for more so than sudden, intense, and unexpected pains. An evaluation of cognitive behavioral therapy approaches suggests that these techniques can be successful for managing chronic pain. Keep in mind that one's relief may be contingent on how long a person has had the pain and how engaged they are in managing and or eliminating the pain. Well, I want to thank you for tuning into a presentation dealing with pain and managing discomfort. I hope that you'll tune into another one of my lectures at some point in the future. If you have any questions, comments, or concerns, feel free to leave them in the comments below or send me an email. Take care.